morning. Today I'm going to talk about the topic diagnosis of pregnancy. How will you diagnose the pregnancy? Once a patient comes to the OPD, she says, I'm pregnant. So on what basis you diagnose the pregnancy? Based on her history, that is history of amenorrhea, and then we do the pregnancy test. If it is positive, it is diagnosed as pregnancy positive. And in case of any doubt, and in case of previous history of any ectopic, and that means in tubal pregnancy, we'll do the ultrasound. Otherwise, based on her history of amenorrhea and positive pregnancy test, we'll come to the diagnosis of pregnancy. And if she is pregnant, we have to calculate her gestational age. That is, how many weeks of pregnancy. We'll calculate the gestational age from the first day of the last menstrual period. And based on that, based on the gestational age, we'll come to the, we'll give her expected date of delivery. The expected date of delivery is from the first day of the menstrual period. It is 9 months and 7 days, or 280 days, or 40 weeks. And in majority of the cases, the diagnosis of pregnancy is usually straightforward based on the pregnancy test and history of amenorrhea. And in case of irregular cycles or irregular vaginal bleeding, the diagnosis of pregnancy is a little bit more complicated. So for that, we need definitely we need ultrasound, and we need thorough history and previous 3 cycles history. We have to take the history of previous 3 menstrual cycles. So based on that, we can diagnose a pregnancy. How many weeks of pregnancy? For the diagnosis of pregnancy, we can simply do the pregnancy test. Why we need to diagnose the pregnancy? She comes straight away, come to the OPD, and she might say pregnant, and after that she come at the labor pains and she can deliver. Why we need to diagnose the pregnancy? Early pregnancy diagnosis allows the commencement of prenatal care. That means the patient should be taken care of from the beginning of the pregnancy, and we will be given supplementation and potential medication changes. She might be having comorbidities like hypertension, diabetes, and thyroid disorders before pregnancy, so that, and epilepsy. Some medications has effect on the fetus, so that we can change some medications and we can reduce the dose. Sometimes we need to increase the dose. So for that, we need early pregnancy detection diagnosis. And we lifestyle changes to promote a healthy pregnancy. That means appropriate diet, avoidance of alcohol, tobacco, and certain medications. In case of sometimes the pregnancy is not planned. In that cases, early pregnancy, if they need, we can terminate the pregnancy. If it is detected early, it will be easy to terminate. So based on the gestational age, we divide the pregnancy into 3 trimesters. For the medication, for the follow-up, for the visits, for the convenience, it is divided into 3 trimesters. Trimester is first 12 weeks. The second trimester is 13 to 28 weeks, and the third trimester is 29 to 40 weeks. And what are the things we do? What are the changes we diagnose in the first trimester? That is in the first 12 weeks. The first 12 weeks, if the patient comes in the first 12 weeks of pregnancy, that is in the first trimester, the symptoms what we regularly see is, as we have seen, the history itself is the cessation of menstruation. Menstrual period itself is the pregnancy symptom. But sometimes there is a slight bleeding at every month at the regular intervals. For the first 3 months, there might be slight bleeding, like menstrual at the correct exact time of the menstruation. But it's not menstruation. That is a slight bleeding at the expected time of menstruation. Rarely occurs in the first 3 months. That is scanty, not too heavy. If it is too heavy, we have to confirm it as abortion. If it is slightly at regular intervals, it is called Hartmann sign or placental sign. That is implantation bleeding. This the most common thing is in the first trimester, what we diagnose is morning sickness. That is, in 50% cases we see morning sickness. It usually appears soon following the menstrual period, That morning sickness is nausea, vomiting, especially in the morning on rising from the bed. Usually it disappears after the third month, but sometimes it may prolong, and sometimes in some cases it might be persist throughout the pregnancy. And one more one more symptom we regularly see is frequency of micturition. Due to congestion of the bladder and irritation of the bladder by the growing uterus in the first trimester, frequency of micturition increased, because until 12 weeks of pregnancy, the uterus is pelvic organ. It might be pressing the bladder, so frequency of micturition is increased and more prone to infections also because of the congestion and irritation, and resting of the bulk uterus and the bladder and the anteverted position of the uterus. Change in maternal osmoregulation leads to increased thirst and polyuria. Usually disappears after the third month once the uterus is the pelvic organ. From the pelvic organ to abdominal organ. The other change is breast symptoms. There is breast enlargement, heaviness, discomfort, and pricking sensation. It's a discomfort. So many patients come to the OPD in the first trimester itself. They're feeling so heaviness in the breast. So much pain. For that is we have to reassure them that is the symptom of pregnancy. It's nothing to be worried about that, and it usually disappears in it usually appears in 6 to 8 weeks, especially in primigravidas. And one more thing, they complain about is in pregnancies, appetite changes, craving for certain types of foods, that is pica, that is it is unedible, and craving for food, and refusal of other types of what they regularly like the food they don't like at the pregnancy. They like to they want to eat some foods. They crave for some types of foods which are not edible also. And the most common one more symptom is frequent symptom that may occur in pregnancy is fatigue, easy fatigability, and a tendency to sleep. But if it is fatigue is not relieving with rest, we need to, if it is fatigue is associated with any breathlessness, we need to check for anemia. Is there any hemoglobin deficit? Until now, we discussed about the symptoms of first trimester pregnancy. Now, the signs, what we see, the patient won't complain about this. We see in our observation, these are the objective signs of pregnancy. These are the breast signs. The patient comes and tells there is breast pain, there is breast discomfort. But on examination, we see increased size and vascularity, that is visible veins, relative visible veins, and increased pigmentation in the nipple and the areola, pigmentation in the primary areola, and appearance of a secondary areola is seen in the pregnancy. Especially we notice it in the primigravidas. In second gravidas, it's already in the previous pregnancy changes will be already persisting, so we may not notice that much variation. So it is more prominently seen, seen in primigravidas, more clearly seen in primigravidas. And appearance of Montgomery tubercles in the areola. Those are the dilated sebaceous glands. And in some pregnant ladies, we can see the milk secretions, that is colostrum. It may start as early as 12th week. That is in first trimester. If this is the changes, these are the changes what we see, the breast changes what we see in first trimester. And coming to the abdominal examination, until 12th week of pregnancy, the uterus is pelvic organ, so we won't feel the pelvis parabdominally. So parabdomen is soft, but for some people it may be just suprapubic bulge. But anyhow, until first trimester, until first 12 week of pregnancy, it is pelvic organ. We cannot feel abdominally. We don't need to, even though if we do the abdominal examination, we won't feel the uterus. Pelvic changes. These are also the changes what we see. This is not pursued with the patient. These are the changes what we see. Jochmer sign, Osiander sign, Goodell sign, and These are the early physical changes of the signs of pregnancy. Blue is discoloration of cervix and vagina is called Chadwick's sign. And softening of cervix is called Goodell's sign. And softening of uterus, that is called Hagar's sign or Ladin sign. The darkening of nipples, unexplained pelvic or abdominal mass. Jacquemus sign, this is also known as Chadwick's sign. This is dusky hue of vestibule and anterior vaginal wall visible at 8th week. More pronounced as pregnancy advances and is more definitely present in the multipara than not like a premigravida what we see in the breast changes. This is more prominently seen in multipara. This is due to local vascular congestion. Osiander sign, increased pulsation that is felt through the lateral cornices at 8th week. Goodell sign, cervix becomes soft as early as the 6th week. Softening is more surrounding the external os and also in the upper part. The pregnant cervix feels like the lips of the mouth. On speculum examination, the bluish discoloration of the cervix is visible due to increased vascularity. So, these are the pelvic signs and some other the signs also by manual examination, but we usually don't do in the first trimester unless indicated. The bimanual examination, uterus is enlarged, soft, globular, and Hagar's sign, that is, if we keep the two fingers in the anterior fornix, the fingers on the other hand over the abdomen behind the uterus, the fingers of the both hands can be approximated as the lower part of the uterine body is soft and empty. This is called Hagar's sign. This is more important sign, and the other sign is Palmer's sign. The uterine contractions felt on bimanual examination. This is done by manual examination. These two signs are elicited by manually, Hagar's sign and Palmer's sign. So what are the tests we do in the first trimester? The most common, usually with the pregnancy test, once the pregnancy test is positive and ultrasound confirmation, we don't do these laboratory investigations so extensively for the immunological assays. But in case of any previous history of an abnormal pregnancy and in ectopic pregnancy, in case of twins, in case of molar pregnancy, we do these immunological assays. The most commonly used assays are the beta subunit of HCG. The other hormones, but the other hormones we may be useful. It may be useful progesterone and early pregnancy factor, but this progesterone and early pregnancy factor we normally don't do. The HCG. This hormone is only released by trophoblastic tissue produced by a growing fetus and its associated placenta. HCG is present in the maternal circulation as either an intact dimer, alpha or beta subunit, and degraded form or beta core fragment. Detection of HCG in the maternal serum and urine is evident only 8 to 10 days after conception. This is only after the maternal serum and urine is evident 8 to 10 days after the conception. HCG is detectable in the serum of approximately 5% of 8 days after conception and in more than 98% of patients by day 11. That's why even though if you do the pregnancy test on 28th day of the cycle, some people come immediately next day of the menstrual period. If we do the test, so it will get positive. That means because 98% of the patients on day 11, the serum HCG will be detected. But there is no need to wait until 1 week after the pregnancy, 1 week after the menstrual period. Diagnostic levels in urine seen only about 23-24 days after conception. Levels peak at 10 to 12 weeks gestation and then plateau before falling. Home pregnancy tests. These days, so many people conduct their pregnancy test at home. That is very inexpensive and easy to perform. Most current pregnancy tests have sensitivity to approximately 25 to 35 milli international units per ml. Ranges from 25 to 100 milli international units per ml. As a medical student, any neighbors come to you and may ask, can you check the pregnancy because I missed the period? They might ask you. So it is easy to perform. After open the kit and place 3 drops of urine placed in the S basin in the kit, and a solid line appears at the C area. For every test, it will be coming. After a minute, another line appears at the T area that indicates the patient is pregnant. If the That means T means test, C means control. Control is always the thick line. The test comes, T line comes thick, that means pregnant. The pregnancy test positive. It comes thin, or it won't, if the line doesn't appear, then it is negative. If it is thin line, it might be in the early stage of HCG levels are not enough or false positive. So we need to repeat after 48 hours. So this is the how test and control. This is the test where the only one line is seen, that is negative, two lines seen, that is positive. Urine pregnancy test, classically it becomes positive 7 to 10 days after the missed period. And commercial testing kits are available that are sensitive to 25 international units per liter. By the time the mother has missed her first period, her HCG levels around 100 international units per liter. So that once she missed the period, the test comes positive. No need to wait for longer time. Serum pregnancy test. This is not routinely done. This is done in case of suspected ectopic and any threatened abortions and any blighted woman. In that cases, it won't become positive. The HCG levels are not up to the mark. So it becomes classically serum pregnancy test positive 5 to 7 days before first missed period. So, but we usually don't do the serum test to diagnose the pregnancy. A quantitative serum HCG levels of greater than 5 international units per liter will usually denote a pregnancy. With a normal intrauterine pregnancy, the HCG levels doubles approximately every 36 to 48 hours. Blood test for HCG. These are not usually done. These are also for blood tests are usually done for follow-up of molar pregnancy and any threatened abortion and any ectopic pregnancies. Failure to achieve the projected rate of rise may suggest an ectopic pregnancy or spontaneous abortion. On the other hand, an abnormally high level or accelerated rise can prompt investigation into the possibility of molar pregnancy, multiple gestations, chromosomal abnormalities. False negative HCG usually involve urine and are due to qualitative nature of the test. The reasons for the false negative: an HCG concentration below the sensitivity threshold of the specific test being used, a miscalculation in the onset of the missed menses, delayed menses from early pregnancy loss, delayed ovulation or delayed implantation. Usually false negative HCG is a miscalculation in the onset of the missed period. Serum progesterone, this is usually not done regularly, but it is very can reliably predict pregnancy prognosis. This is also not regular. Early pregnancy factor, this is also for theoretical purpose, but we don't do this test regularly. Ultrasound. Nowadays, this is the most common investigation after pregnancy test. After urine pregnancy test, this is the most common investigation done routinely. The identification of gestational structures by ultrasound correlates with the specific levels of HCG, termed discriminatory levels. A discriminatory level is the level of HCG at which the structure in question should always be identified. Most experienced transvaginal ultrasound operators should visualize the gestational sac when the levels are approximately 1000 milli-international units per ml. The discriminatory level for the gestational sac is approximately 3600 milli-international units per ml, and if it is not seen at this point, other pathology must be excluded. The yolk sac is commonly observed with the HCG level of approximately 2500 milli-international units per ml. The embryonic pole usually becomes evident at the level of approximately 5000 milli-international units per ml. Fetal heartbeat can be seen in the vast majority of normal gestations when the HCG levels reaches 10,000 milli-international units per ml. Intradecidual, in the ultrasound, intradecidual gestational sac is identified as early as 29 to 35 days of gestation. So if we see the sac, gestational sac, immediately after the missed period. But for the yolk sac, we don't see yolk sac or fetal pole at the at first at missed period 28 to 30 days. Gestational sac and yolk sac after 5 weeks. Fetal pole and cardiac activity usually by transvaginal we can see at 6 weeks. But transabdominally, we can see the cardiac activity at 7 to 8 weeks. Embryonic movements will be seen at 7 weeks. Doppler effect of ultrasound can pick up heartbeat reliable by 10th week. This is transabdominal ultrasound. This is the fetal pole. This is how to perform the transvaginal. In the first trimester, the gestational for the calculation of gestational age and early trimester, in case of irregular cycles, we need to depend on for the gestational age, we have to depend on the ultrasound, because some people will be menstruating very irregularly. One cycle at 45 days, on another cycle at 60 weeks, 60 days, and another cycle at 30 days. So some people will be getting periods very irregularly. In that cases, we cannot calculate gestational age. In that cases, we have to completely depend on the ultrasound. In that cases, in the first 12 weeks, for the gestational age, we have to measure the crown rump length. So until now, we learned what are the things we have to do in the first trimester, the signs and symptoms of the first trimester. We're coming to the second trimester. In the second trimester, as we know, that is amenorrhea will be continued. Sometimes morning sickness will be continued or a little bit decreased. In quickening, and the new symptom we have seen in the second trimester is quickening. That is perception of fetal movements by the pregnant woman. Usually, primigravidas feel the fetal movements at 18 to 20 weeks. In multiparas at 16 to 18 weeks. And after first trimester, after 12 weeks, the uterus will be the abdominal organ. So we can feel the abdominal enlargement, and we can feel the abdominal signs and abdominal growth also. So abdominal examination or inspection, linea nigra, that is the midline darkening at the midline from the symphysis pubis to xiphisternum. We can see the dark line, that is linea nigra. It is more evident from the 20th week onwards. See, this is the linea nigra. These are the stria gravidarum. These are the abdominal stria, both pink and white, visible on the lower abdomen, more towards the flanks. These are because of the stretching of the abdomen, and the collagen fibers break up and make the stria on the abdomen. These are the abdominal stria. This is on inspection, we see the linea nigra and the abdominal stria. On palpation, this is how we measure the how many weeks of gestation on palpation. So this is the symphysis pubis. If the uterus is at symphysis pubis, that is 12 weeks. So until first trimester, we can't see abdominal enlargement. That is just we feel some just feel the uterus. That is called just palpable until 12 weeks. From 12 to, we have to divide the abdominal here into up to the umbilicus. At the umbilicus, it is 20 weeks. At the xiphisternum, it is 36 weeks. In between the umbilicus and xiphisternum, it is 16 weeks. Just in between the xiphisternum and umbilicus, it will be every 3 fingers will be divided into 6 weeks. So 26 weeks. After that, the 4 fingers, 28 weeks. So 36 weeks. Here you can clearly see how it was measured. So fundal height, if we measure the fundal height with the tape, each centimeters is week, is considered as 1 week. So if it is 38 centimeters, means 38 weeks. The uterus is abdominally felt. The uterus feels soft and elastic. And in the second trimester, we see Braxton Hicks contraction. Those are the intermittent painless contractions detected by abdominal examination. Active fetal movements can be felt at intervals by placing the hand over the uterus as early as 20 weeks. External bellotment elicited at 20th week through abdominal examination. Palpation of the fetal parts and palpation of the fetal movements by the obstetrician at 20 weeks. Auscultation. Auscultation of fetal heart as early as 20 weeks by Pinar's stethoscope. Auscultation of fetal shuffle due to rush of blood through the umbilical artery. Auscultation of uterine shuffle, soft blowing and soft murmur heard low at the sides of the uterus, synchronous with the maternal pulse. And in the second trimester, we do the ultrasound at 18 to 20 weeks for the fetal survey of the fetal anatomy. Any anomalies can be detected at this gestational age. And fetal viability. And usually we don't do the radiology at the 16th week, but in case of any previous achondroplasia, in that kind of cases, any bony deformities in previous pregnancy, we do the fetal skeletal survey. This is the second trimester. This is the anomaly scan, that is TIFA scan, targeted imaging of fetal anomalies. This is the head. This is the abdomen, fetal abdomen. Coming to the third trimester, and coming to the symptoms, as in the previous trimesters, amenorrhea persists. So she should not get any bleeding in the third trimester. So if she is getting bleeding, any vaginal bleeding, that means some alarming symptom. Enlargement of the abdomen leading to the discomfort of the patient. Palpation or dyspnea following exertion. Lightening. Once the uterus enlarges until after the 38th week, the sense of relief of the pressure symptoms due to engagement of the presenting part. And the frequency of micturition reappears because the head is engaged, means the head is, once the fetus grows, the head comes to the uterus is preparing for the delivery. Then pelvis enlarges, pelvis facilitates the preparing for the delivery of the baby. Then head comes down. When head is engaged, there will be the pressure on the bladder, so increased frequency of micturition. Fetal movements are more pronounced in the third trimester. And these are the changes in the face. Plasma gravidarum. These are seen in most of the people. Butterfly face, and the pigmentation on the face. Cutaneous changes are more prominent with increased pigmentation and striae. Uterine shape from cylindrical to spherical beyond the 36 weeks. Fundal height, distance between the umbilicus and the ensiform cartilage. Junction of the upper and middle third at the 2 weeks. Level of xiphisternum at 36 weeks comes down to 32 weeks level at 40th because of the engagement of the presenting part. Symphysis, fundal height. Upper border of the fundus located by the ulnar border. How to measure the fundal height? I think we have seen in clinics how to measure the fundal height. We have to measure the fundal height by keeping your upper border, palmar, ulnar border of the left hand on the fundus, upper border of the fundus, and the point is marked. Distance between the upper border of the symphysis pubis up to the point marked is measured with centimeter. After 24 weeks only, the symphysis fundal height is significant. So symphysis fundal height is in centimeters, corresponds to the number of weeks up to the 36 weeks. Braxton Hicks contractions are more evident. Once it is nearing by the term, the contractions will be increased. They will be during the labor. They become the labor pains. Fetal movements are easily felt. In third trimester, sometimes we can see the movements also. Palpation of fetal parts and their identification become much easier. Fetal heart sound heard distinctly. And in third trimester also, we need to do the ultrasound for the fetal growth assessment, and any abnormalities like any decrease in amniotic fluid level and any increase in amniotic fluid level. It is if it is amniotic fluid level is less than 5 centimeters, in 4 pockets, they have to, in 4 longitudinal pockets, they have to 4 quadrants, they measure the amniotic fluid volume. If it is less than 5 centimeters, that is considered as oligohydramnios. If it is more than 25 centimeters, it is polyhydramnios. So, what are the sure signs of pregnancy? Auscultation of fetal heart at 10 to 12 weeks of that 10 to 12 weeks by sonography is the sure sign of pregnancy. And visualization of fetal parts by ultrasound. Those are the sure signs. The signs, the diagnosis of pregnancy by history of amenorrhea and positive pregnancy test are those are the diagnostic signs. But that is confirmation and the sure signs of pregnancy are auscultation of fetal heart by 10 to 12 weeks and visualization of fetal parts by ultrasound. And inspection of fetal parts as early as all the parts, means each and every organ, by 12 week. Inspection of fetal movement as early as 20th week. Palpation of fetal movements as early as 20th week. Palpation of fetal parts as early as the 20th week. These are the sure signs of the pregnancy. Auscultation of fetal heart as early as 10 to 12 weeks by sonicate. Auscultation of fetal heart as early as 20 to 24 weeks by Pinard stethoscope. Auscultation of umbilical shuffle as early as 20 to 24 weeks. Auscultation of uterine shuffle. Differential diagnosis. So the patient comes, I'm pregnant because I missed the period. So how will you diagnose either this is pregnancy or not? There may be, it might not be pregnant. There are so many differentials. Uterine fibroid, cystic ovarian tumor, and cystic tubercular peritonitis, hematometra, distended urinary bladder, pseudocysts. There are so many differentials. The first thing is ask the history of if it is history of amenorrhea, then we do the pregnancy test. If it is pregnancy test is positive, then it is confirmed as pregnancy. Sometimes uterine fibroid, the big fibroid may be mistaken for the pregnancy. In that cases, you have to do the in fibroids also there might be menstrual irregularities. The differentiating thing for uterine fibroid and pregnancy is urine pregnancy test. That is the HCG test, urine pregnancy test. Based on if it is positive, can come to the conclusion of a pregnancy, and we can do the ultrasound. By that we can rule out uterine fibroids. So uterine fibroids, there is no pregnancy test positive, there is no HCG, there is no fetal parts on ultrasound. Next thing to rule out is cystic ovarian tumor. This is sometimes amenorrhea may be present or absent. This is also sign pregnancy test negative, and this is also differentiated by ultrasound. And the most common thing is distended urinary bladder. So sometimes urinary retention, there might be the stones, gradual urinary retention, suddenly they feel like that as pregnancy. So after catheterization, the distension will be decreased. And moreover, for every patient who is in reproductive age group, if she is in amenorrhea, she missed the period, we regularly do the pregnancy test. So in that way, we can rule out the distended bladder. Pseudocysts. This is the woman is anxious to conceive. See, she feels that she is pregnant, but only abdominal fat will be there. In that case also, we have to the test. We have to ask the history. Anyhow, she can tell that is she is not menstruating since so many months, and her abdomen is growing, so she might be pregnant. But we do the pregnancy test. We do the ultrasound. We do the physical examination, pelvic examination, and to confirm that is not pregnancy. That is pseudocysts. Hematometra. There might be some stenosis in the hematometra. Usually, in case of any cervical factors, any cervical obstruction, cervical stenosis, what happens is she is regularly menstruating, but not because of the stenosis, there is a blood accumulated in the uterus and it is enlarging. In that cases, we have to do the ultrasound and we need to do the pregnancy test. In that way, we can rule out the hematometra.